Come on. Thank you. Week 1, the cardiovascular valvular heart disease. Major was rheumatic heart disease. Minor was congenital heart disease and cardiomyopathies. So the classic presentation, usually crowded living, unhygiene, young age, fever, arthritis. The complete summary there: 3 etiology, genetic susceptibility, streptococcus, beta hemolytic, and development of autoantibody. Activation of lymph node, antibodies attacking the heart and many systemic organs. Acute phase. In the heart, endocarditis at the border of the valves, within the myocardium and over the epicardium. So it is a pancarditis, plus systemic involvement of skin, joints, meninges, CNS, acute inflammation. Then recurrent inflammation due to unknown reasons only occurs in the endocardium, leading to chronic rheumatic heart disease, scarring of the valves, commonest mitral because of high pressure, and other valves lesser frequency, and the mitral phases, mitral stenosis. Acute rheumatic fever microscopy is inflammation chronic. So it is acute rheumatic fever, but inflammation is a chronic type of inflammation. It is a mismatch there because it is lymphocytes, macrophages with necrosis. So it is not like acute, not many neutrophils. Okay. What we see is accumulation of big macrophages with a central necrosis and giant cells. Can you see all these big giant cells? And usually around a blood vessel, that is the edge of the blood vessel there. Now if you see the whole slide here, that is the myocardium, and this is the intermyocardial tissue or pericardium here, blood vessels there. At the side of the blood vessel there are inflammatory cells plenty, but there are plenty of inflammatory cells everywhere. It is pancarditis, but the Aschoff bodies are seen around the blood vessels in the myocardium. So those Aschoff's giant cells, Aschoff body, okay, the Aschoff body is the whole area of inflammation. Necrosis, macrophages, T lymphocytes and giant cells near a blood vessel. That is the summary there. Pericarditis is effusion of fibrin and clotting of the plasma on the surface. So maximum vasodilatation and leakage of fluid with fibrin. Rheumatic heart disease is a chronic complication of thickening and narrowing of the mitral valve. So all the clinical features, ECG findings, please read about. What I am talking only is that is fibrosis, scarring and adhesion of the mitral valve, leading to mitral stenosis and regurgitation together. Why there is right ventricular hypertrophy, why there is mid diastolic murmur, if I want I will ask you. Right ventricular hypertension, pulmonary hypertension and leading to pulmonary edema and basal cryptus. So all about rheumatic heart disease. Congenital heart disease, At birth VSD is the commonest, but later in life it is ASD is the most common, because most of the VSDs automatically close, membranous VSDs, muscular VSDs remain. Pulmonary stenosis, patent ductus arteriosus, Fallot's tetralogy and coarctation of aorta. So only these, if you know one or two lines, enough. In adults ASD is the most common. Infective endocarditis, acute, subacute. Acute in a normal valve, stronger bacteria. Subacute is abnormal valve, normal bacteria. Okay. Produces vegetations, totally destroy the valve with perforations. So it results in sudden development, usually within few days to weeks, development of new murmurs, machine murmurs. Just know the name, non-infective valve disorders like non-bacterial thrombotic NBTE, that's in debilitated patients, post chemotherapy, dying patients. Liebman-Sachs endocarditis, autoimmune, antiphospholipid syndrome. Endocardial myofibrosis in carcinoid syndrome, and of course the prosthetic valves. Apart from mitral stenosis due to rheumatic fever, the next common clinically is aortic valve calcification, age related, later age, more associated with wear and tear, hypertension, or congenitally abnormal aortic valves, bicuspid aortic valve. It can also occur in rheumatic, secondary to rheumatic complications as well. So thick, irregular, fibrosed, calcified, and calcium deposits in the aortic valve cusps. Cardiomyopathy. When we say myopathy, myositis. Myositis is inflammation, myopathy is something abnormal but no inflammation. Okay. So cardiomyopathies, commonest is the dilated cardiomyopathy. The muscles are weak, muscle fibers are weak, so they stretch, there is more fibrosis. Although in response to stretching they increase in size, but they do not have sufficient power. So it is abnormal cardiac output, defective output. Okay, that's the commonest, commonly secondary to alcohol, but it can also be due to congenital. Hypertrophic cardiomyopathy, irregular, abnormally thick bundles of muscle, and characteristic feature is thickening of the septum, interventricular septum more, and irregular thickening everywhere. Restrictive cardiomyopathy is when the heart becomes stiff. Commonest is endomyocardial fibrosis secondary to carcinoid syndrome and amyloidosis, amyloid deposition. Okay. Now week 2, MI, atherosclerosis, ischemic heart disease. Pathogenesis. First thing you should write is unknown etiology, we don't know. Endothelial damage at the high pressure areas, that is the branching of arteries, starts at a very early age, young children with endothelial damage, deposition of fat, enclosed in the macrophages and forming smooth soft plaques, very early age. Later on in the age, these plaques grow bigger, there is a breakdown of the macrophages, inflammation, fibrosis, activation of macrophages, proteases, complications of the plaques. So the plaques are of two types. When there is more healing, less inflammation, is known as stable plaque, gives rise to stable angina. Vulnerable plaque, when there is inflammation more, healing less, gives rise to resting or unstable angina. Appearance, you all know very well now more. Atheroma microscopy is very simple. We will tell you it is a blood vessel biopsy or a coronary artery biopsy. The only thing you have to look for is there atherosclerosis or not, and if it is there, how much it is obstructing. Extensive plaque, active plaque, very thin cap. So this picture is suggestive of unstable angina. This one is more suggestive of stable angina. This one is very narrow, so most likely collaterals would have developed. Patient may have no symptoms or chronic heart failure, chronic. This one would be an acute MI with a complication of the plaque with thrombus in the lumen. So correlation of clinical correlation there, stable plaques, unstable plaques, acute coronary syndrome. Commonest sites, common complications. Coming to myocardial infarction, the blood supply is from the surface to the pericardium to the endocardium. So the infarction starts from the endocardium, so bigger area is from the endocardium, and always a thin layer is spared because of the surface diffusion and nutrients. No Q waves, Q waves. The difference is partial thickness and full thickness. Important clinically is difference between the different types, locations of the infarct. So I suggest you note down the LAD, the right circumflex, the right coronary, what are all the clinical features, if it is full thickness and if it is partial thickness. Pathology, simple, just like any other wound injury. Immediately up to 4 hours no change, but enzymatically there is loss of glycogen and release of LDH. 4 to 24 hours, 1 day is contraction bands, 3 to 7 days is acute inflammation with necrosis, 1 to 3 weeks is removal of the dead cells by macrophages and granulation tissue, and more than 3 to 6 weeks is scar formation. So it's quite simple. Gross specimen, only two you have to differentiate. Acute, where there is more edema and hemorrhage, darker area, no loss of tissue, that is acute MI. In a chronic MI, it is thinning and scarring. Thinning and scarring, and also there is one complication here, ventricular aneurysm here, slight dilatation there. This is the microscopy, normal muscle fibers, cardiac muscle, central nucleus, 1 day contraction bands, 3 to 7 days acute inflammation, 1 to 3 weeks granulation tissue, macrophages and blood vessels, these are blood vessels, 3 to 6 weeks scar, more than 3 to 6 weeks also scar, gradually reducing. Simple. Complications, acute in the first 10 days is rupture of the papillary muscle, surface pericarditis, intraventricular thrombus. Chronic is dilatation, ventricular aneurysm with again thrombus formation and stroke. That's it. Now week 3, peripheral vascular disease, arterial and venous disorders, mixed bag of all minor learning issues. Chronic leg ulcer was the case, venous, arterial, neuropathic, malignant, infections and others. Differential diagnosis. Leg ulcers are common in 1% of clinical patients, 80% are venous, arterial is 10%, all others together is 10%. So commonest is venous. Venous ulcers causes varicose veins, gaiter region, large irregular shallow oozing wet ulcers, congestion, blood is accumulated not being drained out. So, there will be dermatitis, shallow oozing ulcers. Arterial ulcers are painful, dry, dark and with atrophy of the skin, not dermatitis but atrophy of the surrounding skin. Usually more common at the tips, but it can occur anywhere. Peripheral vascular disease, that is atherosclerosis cause. Neuropathic, diabetes, pressure areas, footwear, ill fitting footwear, painless, clean ulcers with a strong callus surrounding because of hyperkeratosis. Malignant ulcers, you all experts. Year 3 skin pathology. ABCDE skin examination, appearance of an ulcer, malignant ulcer, different colors, locations, different types. Infectious ulcers mainly as a differential diagnosis to rule out the common ones, tuberculosis, treponema, yaws, pinta, more in these tropical regions. Deep vein thrombosis, the risk factors, Varicose trad, the flow of blood under the vessel, stasis, hypercoagulability, vessel damage. Varicose veins is valve defect etiology, either congenital or acquired. People who are standing for long times are congenitally abnormal valves, defective pump mechanism, and because the inner deeper veins are all well protected by sheaths, the superficial veins enlarge. Okay. So, varicose veins. Now, vasculitis, inflammation of the blood vessels, is classified according to how it affects the large vessel, giant cell arteritis, the medium vessel, polyarteritis nodosa and Kawasaki disease, and the small vessels is microscopic polyangiitis, Wegener's granulomatosis. Probably that's 2 is enough, or probably just Wegener's. Autoimmune vasculitis, in many conditions, clinically most common, SLE, IgA nephropathy, Henoch-Schönlein purpura, cryoglobulinemia, so many, good Pasteur's disease, so many can cause small vessel vasculitis. Dengue is a vasculitis, viral induced. Raynaud's phenomenon, vasoconstriction of digital arteries, cold bar emotion, primary, secondary. Secondary is in all autoimmune diseases. In genetic, primary. Polyarteritis nodosa, where you get gangrene and the arteries develop nodular inflammations, segmental inflammation of necrotizing inflammation, PAN. Wegener's granulomatosis, granulomas, giant cells around the blood vessels, same like tuberculosis but without caseation, and it also causes lung lesions similar to tuberculosis, cavities with granulomas. So, sarcoidosis, Wegener's and tuberculosis should be differential diagnosis if you see granuloma within lungs. Buerger's disease, thromboangiitis obliterans, smoke induced hypersensitivity to smoke, common in the males and Jews, but I have seen in India, in my place South India, quite common. Very severe painful limbs, patients literally crawl due to pain, obstruction to the blood vessels due to inflammation and ischemia. Buerger's disease associated with heavy smokers, not moderate smokers. Giant cell arteritis, it can affect aorta as well as small blood vessels, typically the temporal arteries. Focal nodular granulomatous inflammation with giant cells and rupture of the elastic lamina. See, that is the elastic lamina, rupture of the elastic lamina, and that appears as painful nodules on the surface. Giant cell arteritis. Now, starting with the respiratory system, week 4, acute inflammations, pneumonias. Pneumonia, aspiration, bacteria entering the alveoli, multiplying, causing inflammation, exudation, clearing, resolution, or it can go into abscess and complications. Pneumonia, there are many different types, infective, non-infective. Now, infective, bacterial is the most common, 2 types, lobar and bronchopneumonia, and the less common is interstitial pneumonia. Interstitial pneumonias are common with viral and environmental toxins, interstitial pneumonia. According to duration, acute pneumonia, chronic pneumonia. Clinically, primary or secondary pneumonia. Primary means normal person with pneumonia, secondary is patient with a secondary pneumonia. Typical and atypical pneumonia. Atypical pneumonias are with mycoplasma and viruses. Community acquired pneumonia and hospital acquired pneumonia, you all know. Pathology wise, major is lobar pneumonia, bronchopneumonia and interstitial pneumonia. Microbiology important, community acquired or typical pneumonia, Streptococcus, H. influenza, Staph aureus, but commonest is Streptococcus. Community acquired atypical pneumonia, Mycoplasma, Legionella, SARS, Q fever. Nosocomial or hospital acquired infections are gram negative, E. coli, Pseudomonas, gram negative rods. Aspiration pneumonia is anaerobic bacteria. Chronic pneumonias, actinomyces, fungus, tuberculosis. Necrotizing pneumonia and lung abscess in anaerobic, usually in aspirations. So, aspiration pneumonia. Pneumonia in the immunocompromised, that is CMV, pneumocystis, atypical mycobacteria and fungal. Now, the whole pathogenesis I have summarized here. My line diagram of a alveolar wall with capillary, bacteria coming, toxins, inflammation, vasodilatation, congestion. So, stage of congestion, then is exudation of the fluid, clear fluid. Next step is exudation of RBCs as well, full of RBCs with few WBCs, and the WBCs attacking the bacteria there. That is known as red hepatization. Then is the grey hepatization, all the WBCs coming in, digesting the bacteria, and then the resolution phase back to normal. So, 4 phases of pneumonia, usually seen clearly in a lobar pneumonia only. In bronchopneumonia, all the stages are seen in at any time. So, I have just summarized the microscopy here, only fluid with few cells, fluid with plenty of RBCs and few WBCs, plenty of WBCs and only macrophages clearing. Bronchopneumonia and lobar pneumonia, very important to recognize clinically. Bronchopneumonia is abnormal lung with infection, lobar pneumonia is normal lung with infection. Broncho is extremes of age, lobar normal persons in the community. So, all other differences you read about. Briefly, chronic pneumonia and interstitial pneumonia. Interstitial pneumonia and chronic pneumonia most commonly. The inflammation is in the alveolar walls, very little in the alveolar lumen. So, thickening of the alveolar walls. Non-infective pneumonias, drugs, lipoid pneumonia, aspirations. and even malignancies. Now week 5 is chronic infections, chronic damage, COPD, emphysema, chronic bronchitis, asthma. Pathogenesis of COPD is any toxin activating the macrophage, enzymes, recruiting the neutrophils, proteases, and damaging the wall. Okay. When it damages more bronchial wall, then it is bronchitis. When it is damages more of alveolar wall, it is emphysema. And clinically there can be combination of both, then when we call just COPD. Alpha 1 antitrypsin deficiency normally inhibits, so deficiency of alpha 1 antitrypsin deficiency leads to early COPD development in very young age. Gross appearance difference between chronic bronchitis and emphysema. Chronic bronchitis, inflammation in the bronchial tree and the terminal bronchiole only, not the alveoli. Pure emphysema, damage only in the alveoli, not much in the bronchus. The pink puffers and blue bloaters, the clinical features. COPD commonly overlaps, that is what I mentioned already. So emphysema, chronic bronchitis and asthma together, all three together known as COPDs. This is the microscopy. Normal lung, thin alveolar wall, alveolar duct. Here is inflammation, that is a bronchiole, and here is plenty of inflammation around the bronchiole. Chronic bronchitis and damage to the alveolar wall is emphysema. Restrictive lung disorders are where the lungs become stiff or the thoracic cage becomes stiff. So if the lung becomes stiff, it is intrinsic, sarcoidosis, pneumoconiosis, anthracosis, silicosis, asbestosis, all those, tuberculosis and interstitial pneumonias. Extensive disorders are scoliosis, kyphosis, severe obesity, Pickwickian syndrome. Have you heard of this, Pickwick syndrome? Better read. Pickwick syndrome. Pleurisy, rib fracture, anywhere where the thoracic cage becomes stiff. Neuromuscular disorders, rare, paralysis of the diaphragm, myasthenia gravis or polio. But the most common for us is now sarcoidosis and pneumoconiosis, where there is pathology. Destruction and fibrosis, that is the pathogenesis. Now silicosis, briefly, silica, sand and stone dust mining, scattered multiple nodules of fibrosis, round scars which appears on the X-ray as fine granules and microscopically rounded scars surrounded by irregular emphysema. The scarring pulls the alveolar walls and ruptures. Okay. Asbestosis, initially pulmonary edema, effusion and later fibrosis. It is the fibers which are highly reactive, they are coated by protein and they are highly allergenic, hypersensitivity. Coal miner's lung, just the dark black pigment usually does not cause much damage, only color change, but associated with anthracosis, associated with silicosis causes the damage. If it is pure anthracosis, usually no fibrosis or damage. Sarcoidosis, we just discussed, unknown etiology. I have put a patient case of my friend. Abnormal immune reaction, producing granulomas everywhere, but more with the lungs and also in the skin, granulomas, just like tuberculosis with the giant cells. You can see those giant cells, but no caseation. Multiple fine nodules, presents like tuberculosis without caseation. It is unusual in a smoker, so probably this is one good thing if you are a smoker. Difference between restrictive and obstructive, you will be dying of many other things, of course. You will not die of sarcoidosis. Okay, difference between restrictive and obstructive disorders, you should remember, important because we asked this giving an LFT example. So, FEV1, FVC, what is the difference between these two, restrictive versus obstructive? Asthma is combined, it is obstructive as well as restrictive. Inhaled antigens, thickening of the bronchial tree causing obstruction, plenty of eosinophils, early phase and late phase reactions. Microscopically, you will see plenty of glands, hyperplasia of the mucosal glands, just like chronic bronchitis, but the only difference is plenty of eosinophils in case of asthma.